we reached a point where there were multiple clinical failures in the anesthesia program. This is a nurse anesthesia program at UTC. It's been in existence for quite a while. The students come in, they're excellent, and yet they were not completing the program. And so we stopped and really looked at what was going on. And this is the background of the study that you need to know to understand what we're working on. We had very high attrition rates, where the usual is about 10%. It had climbed to 29%. You see that kind of number, and you have to stop and ask yourself, what is it that's going on? Something is very wrong in the situation. And when we started looking at what was going on, the failures and people were leaving or withdrawing because of clinical failures, not because of didactic failures. So they were being successful in the didactic courses that hit the clinical time, and they could not perform. And if there's anywhere you want somebody to be able to perform well, it's in the OR, putting you to sleep and waking you back up again. Critical ability. The other thing that was happening, the people that usually apply to the nurse anesthesia program are ICU nurses. And they have clinical time under their belt. They're considered experts in their practice arena. And they were moving into the OR in a new role. And that transition was becoming very difficult for some people. And it was unpredictable. We didn't know who would be successful and who would not be successful. So this started us really thinking, how can we predict what students are going to be successful in the nurse anesthesia program? Realize that when they withdraw, we lose that person. We can't simply plug in another person because they move through the program as a cohort. So it's critical that we keep those numbers in the program. For the student, they have invested time, they have invested a huge amount of money. So it really is critical for them as well as for us to be able to be successful in the program. So we started talking about, well, how do we predict who's successful in a nurse anesthesia program? So we hit the literature. What academic doesn't start with the literature, right? So we started looking at the literature, and there was lots and lots of research on the cognitive abilities that can be identified in a variety of ways of students and how well it functioned as a predictor of success in a program. And absolutely none of them are predictors of success. There is no combination or no single cognitive variable that is a sound predictor of success in the nurse anesthesia program. Interesting notion. And then what the authors of the research started bringing up as an issue is we need to investigate the non-cognitive factors of students, because it must be in that area that these things that we want to be able to use to predict success must exist. So research was done looking at age and gender, and older female students are the highest rate of dropouts in the nurse anesthesia program. Interviews are also used in all anesthesia programs to assess a multitude of things. These are very rigorous interviews. The students talk about them for years afterwards, about what that interview process is. And it allowed the interviewers to assess a variety of characteristics in the students. However, there's really not anything out there in the literature that says X predicts success for any particular student in the nurse anesthesia program. So we started really looking at the CRNA, and this is the certified nurse anesthetist. These are people that have survived the program and are now out in practice. And we wanted to be able to identify some characteristics of them. We know they have to have some degree of cognitive ability. We know they have to have some degree of interpersonal skills because everything that we do is with our colleagues of a variety of sorts. So they have to be able to relate to other people. The other thing they have to have that's obviously critical is clinical competency. If they don't have clinical competency, they're not going to survive the program, and they're certainly not going to be able to go out and practice. And then last but not least, what we finally figured out is this notion of judgment and decision making. We don't really have anything that allows us to assess this area of a student, of a practitioner. We have a multitude of ways, as you can see on the slide, of assessing all these other areas. However, we needed something to look at this notion of judgment and decision making. And this is where we connected with all of our people from Vikus, giving us the heart and value tool. Now, what happens when these areas are not effective? If you look at the practitioner, if they are incompetent clinically, patient safety is at risk. And that is one of the things that drives us. If we don't have safe students, we can't have them in the clinical area. You are not going to put patient safety at risk by putting an incompetent student in the clinical area. And that doesn't matter where the practice area is, but I'm talking about anesthesia right now. If there's impairment in their social skills and their interpersonal skills, they're not going to be able to relate to their colleagues, their peers, their faculty, the patient, a critical piece here. IOM, one of their latest reports, has identified poor communication as the #1 cause of errors in nursing practice and in healthcare practice. So this is a critical piece of a practitioner, their ability to relate to people, because we work with people. We're not working with machines at all times, we're working with people. The other piece is the inability to effectively work as an independent practitioner. Graduate students in nursing, as they go back out into practice, will function in an independent role. They may be employees of a professional practice, they may be employees of a facility, but they are considered independent practitioners. They are prescribing, they're making decisions for the care of the patient that they are engaged with at that moment in time. And last but not least, if there's impairment in any of those 4 areas that we identified, chances are that student isn't going to be successful in completing the nurse anesthesia program. So knowing these things, we identified some problems. One up, we don't have really a tool, and nothing has been identified in the nursing literature that has been used to assess judgment and decision making with students or professionals of any kind. Now, you probably have it in other bodies of literature, but nothing in terms of specifically this population of people. And secondly, it really handicaps our ability to predict and manage that potential problem that's coming down the road by people with poor judgment and poor decision-making abilities. And at all possible, we want to be able to know what student might be at risk. And if it's a severe risk, we're obviously not going to admit them into the program, ideally, right? So the purpose of this study was to really test out the use of the Hartman in assessing judgment and decision-making capacity in the nurse anesthesia program. This is a, oops, let me catch up. This is a slide that basically summarizes what the population in the nurse anesthesia program looks like. If you look at it, this is an excellent student on paper. They have strong scores. They are invested in coming into the program. On paper, excellent student. And remember this little notion, something happens when they hit clinical and some of them cannot perform, okay? The students that participated in the study, out of the total population, we had an N of 64, that was 83% of the students. I'm assuming that most of you aren't aware of what a nurse anesthesia program looks like. It's a 27-month program. There are 59 didactic credit hours and a minimum of 3,000 clinical hours. That's in the OR. In the OR, working with the patient, putting them to sleep, waking them back up, doing the pre-op, doing the post-op follow-up. How many people have 3,000 hours of clinical? That's mind-boggling, and that's in a 24-month period. So the first 2 semesters in the program are heavily loaded with didactic, and then it goes into a medium load of didactic with a medium load of clinical, and the end of the program is pretty much total clinical hours. So really heavily loaded for clinical hours. We worked with 3 cohorts. I think this slide helps understand it a little bit better. We caught 1 cohort right before graduation. So that's cohort 1. Cohort 2 was assessed midterm and at the end of their program. And cohort 3 was assessed on admission. We just finished assessing them at midpoint, and they will be graduating next year, and they will be assessed right before graduation, so that they will have been assessed on admission, midpoint, and end. A little bit different use of the Hartman. Of course, being a university setting, we do all the IRB informed consent, standard protocol for research. And this is where Vikus has been able to step in. They did all the analysis for us. It was available online, and the students did not have to go anywhere to do this. It was done at their convenience. If there were any problems accessing everything, that was quickly addressed by Vikus. So our partnership has been excellent with this. We did some descriptive statistics and some t-test after the fact, which I'm going to talk about. There were 6 indicators that I just want to zero in on today's presentation, and they're listed here. And these are the critical indicators for us in terms of judgment and decision making. Just a note on the data, Vikus has been able to convert the output from the Hartman tool into a 0 to 100 scale and then normalize the data. Not being a Hartman expert, this has made it so much easier to understand and then to use it to explain results to students. They can comprehend it, they understand the notions behind the numbers, and it just has been an excellent means for us to be able to work with this kind of data. This is a summative, This is a summative chart on pre-test data only. And as you can see, the ranges are anywhere around. We have some strong scores across all of these 6 indicators. And I want to stop and look at them a little bit more in depth. If you notice on work judgment, for pre-test on cohort 1, and this is the group that got assessed right before graduation, their mean was 60.71. If you go down and look at cohort 2, which is comparing their pre-test at midterm and assessment right before graduation, you see a trend of increasing scores here. Intriguing notion that 1 year's time, primarily clinical time, this indicator increased. It's not a significant increase on a t-test, but there's a trend here. that shows that there has been some development